Welcome to T-Minus Attending, and I'm your host, Dr. Shishir Shah. I'm a wound care specialist, entrepreneur, private equity operating partner, proud father, and educator. Our goal at T-Minus Attending is to empower new and experienced medical professionals to lead better and live better so they can fulfill their personal professional lives as they grow into their careers. So this is our 7th episode. I'm honored to introduce nationally renowned and our very previous local here in Phoenix, Arizona, Dr. Darren Swenson. He's a group president for Post-Acute care at Team Health. He's part of my senior leadership team. He's a board-certified in internal medicine. He's served many other roles, including being a chief medical officer for Mountain View Hospital in Las Vegas. He was a co-founder and CEO of Swenson Healthcare and U.S. Post-Acute Care. I knew Dr. Swenson years ago when he was a rising star practicing here in Phoenix as a hospitalist, running into hallways, some consults for wound care. And here we are connecting, probably 15, 20 years later. So I'm excited that we made this journey together and kind of reconnect, share some of his experience and wisdom and knowledge. I think he's going to be wonderful for all our audience that are just entering the medical world and becoming attendings, finishing residency. So Dr. Swenson, welcome to T-Minus Attending.
Thank you, Dr. Shah. Great to be here. And as you said, it's been a long journey and great to reconnect with you.
Appreciate it. So tell us about that journey. I know briefly about you that way, and I try not to talk CVs when we chat too much, but it's interesting. Maybe you can talk about your background again and how you connected the dots to where you are today.
Sure, happy to help out. So I came out of residency out of Savannah, Georgia, and came back to Phoenix, where I did my undergraduate, to start practice as a hospitalist back in 2002. And back then, the hospice movement was very early. I think I was hospice number 2,800 or so in the country.
Wow.
And now we have about 70 or 80,000 hospitalists in the SHM. So it was the early days. Loved the practice of medicine at the bedside, in the hospital. Great experience. But it was about 6 months into my practice, I was working with a group, that I realized I couldn't believe that I spent all these years through undergraduate competing to get into medical school, all those years of medical school competing to be the very best, to get into 4 years of residency postgraduate, to find myself going to a hospital to see 20 people, discharge 3 and admit 3 more and go home. Sure, there's much more to life in my career than the next 35 years of doing this. And so, quite frankly, I went to Barnes & Noble, bought a book on how to write a business plan. And 6 months later, I was financed by a bank and started my own practice there in Phoenix, Arizona, as a hospitalist and an outpatient primary care provider. My journey accelerated through being involved with managed care in the hospitalist environment, and met a large group that was regional that was taking capitated risk on inpatients. That's where I really got a chance to learn about risk in a health plan perspective and working with clinicians. My career advanced to becoming a senior medical director about 3 years after graduate from residency, where I was leading an integrated delivery network. So here I was in charge of a 1,200 physician IPA that all care of patients in the outpatient environment, the inpatient, and the post-acute environment up in Las Vegas, Nevada. I spent several years working with them, but realized that I was missing a lot of my skill set of a leader. But I wasn't taught in medical school. I wasn't taught the soft skills of listening. I wasn't taught finance and operations. I was taught to be a great clinician, and I aspired to that every day clinically. So I entered courses from the American Association of Physician Leadership, began to educate myself on everything that was not clinical from medical school. And in 2013, I achieved my certified physician executive degree. And I was one of a little under 3,000 physicians in America with that title and that degree. It was really to position me as a leader, to have a conversation with an administrator, a health plan CEO, or sit down with my colleagues, a clinician at the bedside, and have a conversation about common goals. Shortly after achieving that, I entered a role as chief medical officer, 100% administrative, where I supported a hospital and building heart failure programs. We built 9 graduate medical education programs to advance training for our clinicians coming out of medical school. We built a research program. In this role, I really had an opportunity to stretch myself with HCA and all their data to understand how to take big data and translate it down to something that was meaningful for a clinician. Why are we trying to discharge early at 10 a.m.? Why is it important to be judicious with antibiotic utilization? And why is a hospital CFO asking me to do X? And it's really got a chance to really hone my skills doing that. After 3 years, I missed bedside care, and I was returned back to the bedside and studying Swenson Healthcare and the post-acute environment up here in the Northwest. Built a large practice in a couple of years and successfully sold that off to Team Health. And 8 months later, they asked me to be the group president, where now I serve a function of supporting over 1,000 clinicians across 33 states. And I have responsibility for profit and loss, execution, strategy. And most recently, we started our own accountable care organization, which went live January 1st this year.
That is impressive and a lot to digest for our audience, and probably can have a sort of podcast for each fragment of your life and your history and your journey, and write a book. I hope you're working on this book as you go into your retirement years. That's impressive. And one thing I caught on about that, and I didn't really even think about it until right now, is we're sort of in that startup society or tech and AI, and I'm going to launch a startup. But you basically were doing startups, and you were coming up with concept, funding yourself, learning on your own, having lonely nights as what that is as an entrepreneur, and especially a physician that started learning the business part of it. And I think you have a lot of good takeaways in what you're talking about, that it's important to learn, okay to take risks, because often, in our industry, we're risk averse. We have a stable job, we go to school, we show up, we get paid. But if you want to do great things, you have to kind of put your neck out there, and it can be lonely, but the reward at the end of the day for someone like you is probably just even midway through your career at this point. There's a lot you can accomplish in a short time, and that's impressive. So kudos to you. You mentioned post-acute care. I obviously know about that because I work with you, and I'm involved in the same arena. But when we went to medical school, I didn't know what post-acute meant, and nursing homes just meant, well, when you get old, you stay there where no one can take care of you. But I didn't know what that meant on the medical paradigm and the whole continuity of care. Maybe if you can explain a little bit more about where you see that impact of the patient journey and where the future of medicine is, because that's a big part of what you do.
It is a big part. As I stated earlier, when I went back to bedside care after having a very successful career for 15 years, I wanted to see where I could make the greatest difference, a true impact. And post-acute, which is all patients that are essentially in the nursing home, whether they're for skilled therapy for a couple of weeks or they're a resident of the facility for life. When they're a resident in the facility, that becomes their home. A lot of times they share a room with someone else. Dignity is a challenge. Privacy is a concern. But their home and their bedroom and that room becomes their life. They have pictures. I said patients with pictures back from World War II and the Korean War, multiple generations of family. And it just reminds you that when you sit down at the bedside with a patient who may be 80, 70, 80, 90 years old, you're entering their home. They're allowing you to be there and giving you the permissiveness to care for them. And I think it's so important for us as clinicians and clinician leaders is not to forget why we became a clinician. We became a clinician, I hope, to take care of people, to do good, and ultimately to pass down the learnings of our career to the future generations of clinicians to make a broader impact in the years to come. When I worked in post-acute care, developing my practice, it's an opportunity to really raise the bar. We used to think about the post-acute environment as a hospitalist as a black hole of medicine. You discharge them from the hospital and you hope they don't come back.
Yeah.
But in leadership, we say that hope is not a strategy. And so I decided to do something about it intentionally by building a practice and raising the bar here in the Pacific Northwest. And interestingly, just showing up with a white lab coat and communicating with the nurses and providing some basic systematic changes in delivery of care raise the bar materially overnight. And as a clinician in today's healthcare environment, there's very little gratification for us. It always feels like a job instead of a profession. But here in the post-acute environment, it still feels special. The nurses appreciate when you come in, and the families and that generation of patients is from what I refer to as the old Marcus Welby generation. They appreciate the clinician, and they still hold them into a sense of thankfulness to come take care of them as patients. And for myself as a clinician and the clinicians I work with today, we remind ourselves that it truly is an opportunity to care for people. It's not our right as physicians and care providers.
Yeah, I like what you said, is bringing back to the roots about the sort of the love of medicine and why we do what we do to take care of patients. And I'm sure you've been caught in the crosshairs as I have. I used to work in emergency medicine as well. And in wound care, there's a lot of litigation and so forth and risk. And often we're playing defensive medicine. But when you're in an environment where it's nurturing and they appreciate you for being there, they know you're doing the right thing. You're doing the right thing for sure. And that inherent bond and trust is there. You start becoming a doctor, a friend, a colleague, family member with them, more than worrying about, did I give them full disclosure on everything I'm going to do for them? There's that inherent trust. Like, I trust you, do the right thing for me, and you get to enjoy coming in. And there's a lot of value. I have to say, I share that experience with you working in the post-acute environment. And any of our audience that gets to spend time in there, not everybody will, or at least appreciate your colleagues that are doing that work. There's a lot of heavy lifting we do on that side. That's very, very important. So thank you for sharing that. So you do a lot of things, obviously, and we only know part of it. But what keeps you up at night? What worries you about? Could be non-professional, but you manage a lot and juggle with a lot. What do you worry about?
I'd say fundamentally, my primary worry is for my clinicians. I worry about Congress's efforts to reduce provider pay, trying to take cuts every year. When we think about inflationary pressures and the challenges of the healthcare environment today, and the more work we ask of our clinicians, whether it be the right intention or not, it's still more work. When we do that and we continue to challenge cutting their pay, there's a point, an inflection point that's going to happen where the quality of care is precipitously going to drop off. Now, Medicare has said that by 2030, that all Medicare patients will be aligned with a value-based care program, some form of accountable care, whether it be Medicare Advantage or our Medicare Shared Savings Program. They are looking to do away with the fee-for-service system. It is my belief, with the pay cuts over the last 5 of 6 years for primary care, that if they continue to cut down the compensation for our clinicians on a fee-for-service model, we get to a point where they force us into a value-based care program. And they've declared this openly, that all Medicare patients will be by 2030. So now as clinicians, we have to figure out, as clinical leaders like myself and yourself, we have to figure out how we educate our clinicians to work and be successful in an outcomes-based world that's data-driven. It's no longer the fact that we saved your life in the emergency room or that we preserved your leg from that wound. It's about how much more is your mortality, what it costs to deliver that high-quality care, and was the patient satisfied. As clinicians, we're not going to beat that system. We have to figure out how to survive and be successful. So I think every day, as you may have experienced at Team Health, it's all around creating resources and tools for our clinicians to be successful. If they want to continue working in medicine, because this train has left the station, we just got to get on the train and somehow get on the front edge of the car.
Yeah, I think, a lot of us are worried, and I'm glad you're bearing a lot of the weight for people out there as well, because, it's about the future and how we're going to make an impact while we're competing against these forces that we may or may not have complete control over. And look, a lot of it is really, cost containment, as you know, and our organization, as well as many, are using advanced practitioners to alleviate the shortage in healthcare, cost containment. And obviously we rely on that for quite a bit because there's only so many patients you can see in a day. Any thoughts on that and how the future looks involving that as well, especially we work with a lot of them and many of our colleagues do?
I've thought many times about the role of the advanced practice clinician, whether it be a nurse practitioner or a PA. And I wondered 20 years ago how we actually took care of medicine without so many APCs, as we refer to them. And I don't know, was care better or worse? I don't know. The data doesn't really impress me that care has improved materially. But then again, our patient population has materially changed from 20 years ago. It's aging. This year is the first of 4 years is called the Silver Tsunami. Every day, over 11 million people 11,000 people, will turn Medicare age every single day for the next 4 years. That's a massive, significant change in demographics, the acuity of our patients, and the complexity. Sure, they're living longer, somewhat they're healthier, but there's just more people that we're having to take care of. And also, society has become more of an expectation of immediate care. And perhaps years ago, we were okay with seeing the PCP a week or 2 weeks out. If we could get into the vascular surgeon a month out, it'll be okay. Somehow we took care of all the people without the APCs. But to your point, about 65% of our clinicians in the post-acute here in Team Health are nurse practitioners and PAs. I've worked side by side with them. I've met with them. I've reviewed their cases in many situations. I'm generally impressed by the quality of care they give our patients. In the post-acute environment, for the most part, our patients are stable. It's a great environment for APCs. And for the physicians, it's really allowed the physicians to take a step back and to deal with a more complex patient, to deal with polypharmacy and medication reduction, to deal with state surveyors that we focus on in post-acute environment, and to look at more systemic change versus every cough and earache and foot problem that, quite frankly, the nurse practitioners and PAs do a remarkable job with. But I've also, on the complex patients, in numerous occasions have had a nurse practitioner or PA who's identified someone going into sepsis because they had the time to be with that patient. They knew them from continuity of care, and they knew there was a change in the patient's behavior. And I will tell you, there's an unlimited number of people I can remember through my career in post-acute at the bedside where an APC has saved someone's life. And if it was just me, the outcome might have been very different and not so good. So I'm blessed to have the APCs working with us. I do have concerns about even some articles that have come out recently in the media about the nurse practitioner kind of diploma mills and what really is the quality of their training. One could even say that sometimes about residents in today's environment and the training programs. But the G&E programs are more structured for the physicians. We just have to be really thoughtful and intentional about asking the right questions on interview. And even so, when we do bring them on board, we have to give them a lot of attention to ensure they have a successful experience. We keep an eye on them for our patients' safety, but we also help them to grow just like we wanted to grow in our internship and our residency years. Really shouldn't be any different. So I'm excited to have them here. I think we'll have a growth in that part of the industry. And the post-acute environment, according to the data, is actually going to go from about $820 million in terms of services delivered to $1.6 trillion by 2032. We're going to need every clinician who's licensed and capable to take care of our patients.
I think you make a very valid point, and there's a lot of arguments out there about utilization, med levels, and obviously we're not here to discuss that. But one thing, I talk about a lot of our themes here is leadership and watching each other's back. And one thing I've learned is if you work with the right team members, nurses, PAs, NPs, techs, staff, even the local cleaning crew in your nursing home, you're watching each other's back. And if you have good people around you, extended set of eyes, it can prevent that sepsis, that admission. We're humans as physicians. We overlook things. We can miss things. And back in the day, I did remember, we work long hours. We still do, but we work long hours, covering a lot of ground. By the end of the day, our bandwidth starts diminishing after a 12-hour day, a 10-hour day. You lose focus. You tend to make mistakes. Obviously, we have stopgaps with EMRs and tools and protocols, but I can tell you the same, that when you have more hands on deck, it takes a village, and you collaborate, you discuss, and communicate, good things happen. And as leaders and as clinicians, we need more. And as you know, we have a crisis in the country. There's a tsunami of work. As you mentioned, the rise in need and services in post-acute, but in the acute setting as well. We're recruiting foreign medical graduates of all sorts because we don't have the supply that's meeting demand. So whatever it is, we have to embrace, and as leaders, we have to be, like you said, working on the difficult cases, really making an impact where they can use our skill set and our experience while they can handle a lot of the bread and butter, because it is a now society. It is, sadly, everything about Amazon and same-day delivery. I think healthcare has become the same way as well. I didn't think of it that way, but I think you're absolutely right. And appreciate you sharing that. We may not have all the answers here today, that's something that our audience needs to keep in mind, be mindful about. So I appreciate that. We talked a lot about serious things, and you obviously keep on top of your game. What do you like to do to decompress, have some fun? What are your hobbies?
So it is so important as a leader, and I say to other leaders who are aspiring to grow and clinicians who want to get into the leadership world, it's definitely not sitting in the ivory tower and just kind of golfing on Wednesdays and taking long lunch breaks. It's anything but that. And it's a very lonely place in leadership because your inner circle is very small of confidence that you can talk about complex or confidential information. And so you have to have an outlet. Over the last couple of years, I've developed an outlet of gardening. And so I spend a lot of time on my property since we have the blessing to work from home, our home office. And so my outlet is to go out into garden, to work on my grass and plant trees. And it just allows me to decompress and reflect through the day of events and meetings, complex meetings that had a different outcome than I expected, sometimes not so pleasant and or positive. And to think through how that happened and what I could have done differently as a leader to facilitate a better outcome for the group. And other times when I get positive news, which doesn't happen all that often as a leader, usually you're dealing with all the problems, and give it equal amount of time as to what worked and why did it work? How did we get a positive outcome? And how can we do that again? Because when we have a positive outcome, a lot of people are impacted by that, just as much as a negative outcome. Our job as leaders is to find consistency and predictability in creating a positive environment whenever possible. And so the gardening allows me to just decompress, get some alone time, work through that. And then I get to look out my window and see my green grass and my trees growing. So it makes me very happy through the day.
I'd love to hear that. I don't have a green thumb. Everything I try to grow dies. So I'm going to have to take tips from you, or maybe it's just the hot desert I'm in. But it's great. I think what you're doing, I could call it that active meditation almost, where you're doing something, but you're quiet, you're peaceful. Maybe no thoughts in your mind. Maybe there are thoughts in your mind, whatever they are. It's disconnecting a little bit. Some people have to turn their cell phones off, go on vacation. But like you said, you need those intermittent breaks. Our minds are taxed. Cell phones, internet, text, emails, meetings, Zoom, podcasts like today. There's constant input and not that much output. So relative to the input. So I'm glad you mentioned, I don't think we talk about it enough, and I don't think we take those breaks, those necessary breaks in our day and in our lives to become effective clinician leaders. So I'm glad you gave that example, and love to hear that. Heard all sorts of things. Many of our attendees have done dancing and sports and bungee jumping and, like you said, gardening. So you mentioned all about educating. You obviously went through a lot of self-training, read books in Barnes and Nobles. Your first startup was really learning on your own with a business plan. I always tell my students and residents you should at least read one finance book, article, journal a week, because that's something you don't do. You're not versed in that. You don't know the language. A lot of it's just the language, just like medicine has its own vocabulary. Any favorite reads you recommend, or really kind of pivoted your career you thought was a go-to, or even general categories you recommend for our audience?
That's a great question. If I think back through my library through the years, it's changed based on my needs or the gaps that were identified. I will say through the journey, and probably relevant to this podcast, is that I've had 3 private professional coaches through my journey. And at each point I get to a certain part of my career and I have these blind spots, is hiring a coach to help me work through them and to give me tools. And every time they would recommend a book or two, some would recommend many books to supplement me. But my most recent read, and what I have all of my clinical leaders who report to me work with, is a book called Start With Why.
It's a great book. Simon Sinek, is that right?
That's exactly right. Simon Sinek.
TED Talk, yes, love it.
Our job as servant leaders is to support our entire team. Leadership is not about a title and dictating to others around us. It's about listening, being thoughtful and intentional, and giving resources to our team to do the jobs that we hired them for. It took me many years to understand that as a physician. Once I understood it, it became crystal clear of how to build teams and retain them and to achieve our goals. But it always starts with why. Why are we doing this? If we're presenting an idea, or if there's an adverse outcome or a difficult situation with a physician or clinician who works for us, why did that happen? Was it a structural problem? Was it the EMR? Was it operations asking too much of the clinician? Or was it just the clinician's bad decision? But why? Now, let's not just assume the clinician was bad because it was a bad outcome. And I've seen a significant opportunity of growth, not only for my clinical leaders, but for my entire team, of all moving in the right direction, because we start with why. And people don't feel like there's pointing of fingers or assumptions being made, because no one likes that, especially as professionals. So it's a great read and I recommend it to everyone.
That's great advice. And, I've read it before and watched his TED Talks, and it's a wonderful, wonderful advice to start with that. And if you get fancy, a lot of folks talk about root cause analysis and all these fancy words, but it really comes down to that 3-letter word. Why did it happen, or how did it happen? And even for yourselves, why are you doing what you do every day? Why do you wake up? What makes you get out of bed and get excited? And certainly you do, and I do, and want our audience to feel the same and learn like we do. I try to limit our conversations here in our podcast to about 20 minutes, and I always go over, and I know I can speak hours with you and probably have coffee and dinner and talk about our lives and learn. And look, I'm going to talk to you offline, and I know we're going to meet a lot to learn from each other, especially me from you. But I want to ask some final words on leadership, professional, personal fulfillment that you want to give our audience before we drop off today. Any final words of advice?
Leadership is an opportunity to truly make a difference. And people have asked me, why did I enter the field of leadership? My answer has been the same for 20 plus years. As a clinician back as a hospitalist, as I shared earlier, I could take care of 20 people a day and do a good job, balance of life, and have a reasonable income. And I think I did a pretty good job as a clinician. I wasn't the smartest, I wasn't the best, but I also wasn't the worst. I was average, middle of the road. But if I could become a medical director and help 10 clinicians do what I do, then I can impact 20 people a day for 10 clinicians. That's 200 patients I impact a day. Fast forward 20 years, I now impact 2.5 million patient touches a year in the post-acute environment. This is really where I can make a difference. So it's a tough journey. There's a lot of self-effort and taught, a lot of hard lessons to learn, but it truly is worthwhile in my mind when you can help clinicians grow their careers to become leaders and propagate that ability to ask why. Why are we doing this? Why did that happen? And as important, how can we make it better? So I encourage everyone to be a leader in their own realm, whether it be a leader in their facility, their nursing home, their healthcare system, or a leader of themselves to find balance of mental health and great clinical outcomes.
Well, thank you, Dr. Swenson. I love the concept of scalability, what you did, and really impacting more lives. And that's really what it's about, getting out there. And it's one patient at a time, but also you can do it many other ways. So thank you again. Appreciate your time. I know we have to reschedule this, but this has just been amazing. And I look forward to working with you the next year even closer. So thanks for jumping on.
Thank you very much.